Welcome in, everyone. If you're a fellow learner who, just loves gaining thorough knowledge without all that overwhelming medical jargon, you are definitely in the right place.
Yeah, we've got a really fascinating one today.
We really do. So the mission of this deep dive is to explore this massive stack of sources we've pulled together. I mean, we're looking at medical journals, physiotherapy clinic guides, even some government health alerts.
Right, from places like the NIH and the Australian Therapeutic Goods Administration.
Exactly. And we're using all of that to answer one really critical question. Should hypermobile patients see a specialist before treatment?
And the short answer we found in the literature is, well, it's a resounding yes. Because for these patients, standard, seemingly harmless medical treatments like basic physical therapy exercises or even standard surgical stitches. Wait, I shouldn't say that.
You mean they aren't harmless?
Right, they can actually be completely ineffective or worse, actively harmful.
Okay, let's unpack this. Because a lot of people, they hear the word hypermobile and they just think, oh, someone's double jointed or, a bit bendy.
Yeah, it's treated like a neat party trick.
Right, like dropping into the splits or bending your thumb back. But the sources we're looking at reveal this intensely complex world of Ehlers-Danlos syndrome, EDS, and hypermobility spectrum disorders, or HSD.
Which are definitely not party tricks.
Not at all. And the biological culprit here, the root cause for all of it, is faulty collagen.
Yeah, collagen is basically the raw material holding everything together. Your skin, your joints, your organs.
So if normal collagen is like the steel beams holding up a house, is EDS collagen like building that exact same house but using stretchy rubber bands?
That is actually a perfect analogy.
Yeah.
Yes, and that's why hypermobility isn't just about flexible joints, right? It is a total whole body systemic issue.
Because you've got rubber bands everywhere.
Exactly. Every system struggles. And we're realizing this is way more common than old textbooks suggested. There's this recent Welsh population study looking at, I think, 1.7 million records.
Wow, that's a massive study.
Huge. And it found the prevalence of EDS and HSD is actually around 1 in 500.
Wait, 1 in 500? That's a hidden epidemic.
It really is.
Yeah.
But what's fascinating here is why so many adults are misdiagnosed for decades. The standard diagnostic tool, the Biden score, it literally misses them.
How does it miss them? I mean, it just tests if you're bendy, right?
Right. It tests if you can touch your thumb to your forearm or hyperextend your knees. But as we age, our tissue naturally stiffens up.
Oh, sure.
Plus, adults often have old sports injuries or past surgeries that create all this rigid scar tissue. It totally masks the underlying laxity.
But hold on, if they aren't bendy anymore, how do they even know they have it? Like, why would a doctor even suspect a flexibility disorder?
Well, a standard doctor probably wouldn't. That's the problem.
Yeah.
But a specialist knows that hypermobility can be highly regional.
Regional, like just in specific spots.
Yeah, you could have a totally stiff arthritic spine, but your hips and shoulders are wildly unstable.
Yeah.
A specialist will look at your childhood history. Did you have quote-unquote growing pains? Did you bruise super easily? Did you constantly sprain your ankles?
So they look at the whole history, not just the party tricks you can do today.
Exactly. The childhood history reveals that underlying rubber band blueprint.
Okay, so let's take that whole body collagen issue and zoom in on one specific area, because here's where it gets really interesting. Let's look at the pelvic floor.
Oh, yeah. This is a crucial area.
The connective tissue down there is supposed to act like a hammock, right? It suspends the pelvic organs, the bladder, the uterus, the bowel.
Right, and in EDS, because that connective tissue is so stretchy, there's a twofold increase in the odds of pelvic organ prolapse.
Twofold.
Yeah, gravity basically wins, and the organs literally start to drop out of their proper anatomical positions.
That sounds awful. And because of that, there's this massive misconception in general medicine about how to treat it.
Yes, the logical leap most doctors make is, oh, your joints are loose and your organs are dropping, so your pelvic floor must be weak and hypotonic.
Meaning too loose.
Right.
Right.
So they tell the patient they need to tighten it up. But our sources show that up to 63% of patients with chronic pelvic pain actually have a hypertonic pelvic floor.
Wait, hypertonic, like too tight.
Exactly. Overactive, rigidly tight, and completely unable to relax.
But how does a body built out of loose rubber bands end up with muscles that are practically tied in knots?
It's all about the nervous system. Think about how you walk on black ice.
Oh, I totally tense up. Like my whole body goes rigid.
Exactly. Your brain senses the instability and forces your muscles to grip so you don't fall.
Mm-hmm.
Well, for someone with EDS, their pelvic joints are constantly shifting. They are literally always walking on ice.
Oh, wow. So their nervous system just panics.
It absolutely panics.
Yeah.
It uses the pelvic floor muscles to constantly guard and stabilize those loose joints. Over time, that constant clenching becomes their neurological default.
Wait, but aren't Kegel exercises like the holy grail of pelvic health? I mean, if I go to a regular doctor for incontinence, they'll just hand me a pamphlet and tell me to do Kegels.
And that is exactly why a specialist is an absolute necessity.
Yeah.
If you prescribe standard Kegel strengthening to a hypermobile patient, it's a disaster.
Because their pelvic floor is already exhausted from clenching 24/7.
Precisely. It's like telling someone who just ran a marathon to do heavy squats to fix their leg cramps. It's already overworked.
Jeez. So doing cables would just make it worse.
It causes more pain, it worsens urinary urgency, and it actually drives up constipation because the muscles literally can't let go.
Yeah.
Treatment has to start with down training.
Down training.
Yeah, learning how to relax. You need a specialized pelvic floor physical therapist to teach the nervous system that it's safe to let that muscle go.
Wow. So standard physical therapy can actually backfire spectacularly.
Completely.
Which makes me wonder, what happens when these patients decide they've had enough and just, go into the knife? Like, if physical therapy isn't working for a prolapse, surgery seems like the logical next step.
Oh, surgery is a massive minefield for the EDS population because it's something called tissue friability.
Friability, like it crumbles.
Essentially, yes.
Hmm.
Normal surgical handling, just the retracting and clamping, can cause severe tearing. And when they try to stitch the wound closed, the standard sutures can rip right through the skin.
Oh my gosh. So you go in to fix a prolapse and the tissue just won't hold the repair.
Right. Operations often fail because the soft tissue they just tightened simply stretches back out over time. And that's just the mechanical risk. We also have to talk about anesthesia.
Right. The sources mentioned something about local anesthetics not working. Like you go to the dentist, get a shot of lidocaine, and it just wears off while they're drilling.
Exactly. Many EDS patients have a profound resistance to local anesthetics. And when you add in systemic comorbidities, it gets even more complicated. Many of them also have POTS.
Postural orthostatic tachycardia syndrome.
Right, it's a dysfunction of the autonomic nervous system.
Hmm.
So fasting before surgery makes them dehydrated, and then general anesthesia causes their blood vessels to widen.
And their nervous system can't compensate for that.
No, it can't. So you get these dangerous sudden drops in blood pressure or wild heart rate spikes right there on the operating table.
It sounds like trying to perform standard surgery on an EDS patient is like trying to sew wet paper towel together while the patient's blood pressure is on a roller coaster.
That is unfortunately very accurate.
Which completely explains why these patients would be so desperate for a quick, non-invasive fix. And that leads us to that fascinating alert from the Australian Therapeutic Goods Administration, the TGA.
Well, the laser treatments, yes.
Right. So many clinics market these energy-based devices like CO2 or radiofrequency lasers for quote-unquote vaginal rejuvenation.
They market them as this miracle cure for laxity and incontinence.
But the TGA did a massive post-market review, and they literally canceled all of these devices from the Australian registry for vaginal rejuvenation.
Yeah, because there was a total lack of clinical evidence and no long-term safety data whatsoever.
So imagine an EDS patient with already fragile, thin tissue spending thousands of dollars on an unproven laser therapy to fix a prolapse instead of seeing a specialist.
It could be an absolute disaster, which is why, if we connect this to the bigger picture, it proves the core point of our deep dive. Yes, hypermobile patients must see a specialist before treatment.
Because standard protocols just were not built for their bodies.
They really weren't.
Okay, so if Kegels fail and surgery is a massive risk and lasers are banned, what actually does work? Because the sources did have some really good news here.
They did. Specialized care can be incredibly effective.
Right, like customized pacing to stop that boom and bust cycle of pushing through pain, and biofeedback therapy.
Biofeedback is huge because hypermobile patients often have terrible proprioception.
Proprioception, that's like knowing where your body is in space.
Exactly. Their brain's internal map is skewed. So a patient might swear their pelvic floor is relaxed, but a biofeedback machine shows they are actually clenching with massive force.
Oh, wow. So they literally can't feel it.
Right. The machine gives them a visual way to relearn what relaxing actually feels like. We also use pessaries a lot.
Those are the silicone devices that support the organs, right?
Yes, they act like a specialized sports bra for the pelvic floor. It physically props the organs up without needing any surgery.
That's brilliant. And a specialist doesn't just look at the mechanics, they look at the whole comorbidity web.
Oh, the web is so important. Let's take heavy menstrual bleeding, for example. It's super common in EDS.
A standard gynecologist would probably just look at hormones, right?
Right, or look for fibroids. But a specialist knows that EDS is heavily linked to mast cell activation syndrome, or MCAS.
Which is an immune system thing. Mast cells live in the connective tissue.
Yes, and because the EDS tissue is constantly micro-tearing from being so stretchy, it irritates those mast cells. They become highly unstable.
And when they react, they release all these chemicals, including heparin, right?
Exactly. And heparin is a powerful anticoagulant.
Yeah.
It literally stops blood from clotting.
Wait, so during their period, the local tissue is just flooded with an anticoagulant?
Yes. So the blood literally cannot clot properly at the uterine lining, leading to dangerously heavy bleeding.
And a standard doctor would entirely miss that connection. They aren't looking for an immune disorder to solve a gynecology problem.
Never. They'd never put it together.
It is all so connected. So what does this all mean for you listening right now? If you or someone you know has always had that neat party trick body, but now it's paired with chronic pain or gut issues or pelvic floor dysfunction, you aren't crazy.
You really aren't.
Your parts are just communicating through a totally different connective tissue blueprint. Advocating for customized, specialized care isn't just a preference, it is a medical necessity.
I completely agree. And I want to leave you with one final thought-provoking idea to mull over.
Oh, please, dear.
We talked about how the hypermobile nervous system is working overtime, constantly guarding those loose joints. It creates this severe chronic mechanical fatigue.
Just from fighting gravity all day.
Right. So if the brain is constantly burning excess energy just to figure out where the body is in space
Yeah.
and keep it upright, how much of the general anxiety and brain fog, so often diagnosed in hypermobile patients, is actually just pure mechanical exhaustion?
Oh, wow.
If our physical structure dictates our mental bandwidth, we might need to entirely reevaluate how we treat anxiety in this population.
That is wild to think about. It really means the anxiety might not just be in your head, it's literally in your connective tissue.
Absolutely.
Well, thank you all for taking this deep dive with us. Remember to keep questioning those standard protocols, keep looking for the real root causes, and we will catch you next time.